Hi, everyone. Thanks for joining us again for Clinicians Brief, the podcast, where we bring you the conversations behind the content you love. I'm your host, Dr. Alyssa Watson, and today I am welcoming back Dr. DJ Haeussler. Dr. Haeussler is a well-known veterinary ophthalmologist. He is the founder and owner of the Animal Eye Institute, which has locations in Ohio, Kentucky, and South Carolina. The last time Dr. Haeussler joined us, we talked about how to perform an enucleation using the transpalpebral approach. It was a very popular episode. I learned a lot. And today we're going to be talking about a little different procedure, one that I dare say some clinicians might find a little intimidating. And when I say some clinicians, I am absolutely talking about me. So I find this very intimidating. So hopefully you can walk us through this and give me a little bit of confidence. We're going to be talking about how to debride an indolent ulcer using a diamond burr. So thanks for coming on the show again, Dr. Haeussler. How have you been since the last time we saw you?
Yeah, I'm good. I'm great. Thanks for having me again. It's always fun to do these. So I appreciate the invite. So yeah.
Oh, well, we love having you. As I said, kind of in the intro, your episode is very popular. Lots and lots of our audience has listened and watched. But just in case there's some new listeners out there, would you mind just reintroducing yourself and giving just a quick little background?
Sure. Yeah. My name's Dr. DJ Haeussler. I'm a board certified ophthalmologist. Like you said, I have locations in Kentucky, Ohio, and South Carolina. We have a residency program. We have a specialty internship program. I did my own training most of it at Ohio State. My undergrad, vet school, residency, and master's degree were all done at Ohio State. And I did a couple a couple internships at Garden State Vet Specialists in New Jersey. And I guess I've been practicing ophthalmology for about 13 years now.
That's wonderful. And training the ophthalmologists of tomorrow too. So that's great. As I said, we're going to talk about debriding indolent ulcers, but before we even get to the technique, which I think we're going to kind of focus on in the latter half of the episode, I just kind of want to talk a little bit about corneal ulcers in general. For me, sometimes this can get really confusing because it seems like there are tons and tons of different descriptions or ways to categorize corneal ulcers. You know, I've seen them described as like superficial, deep, chronic, uncomplicated, simple, complicated, refractory. So what do you think is the best way to define an indolent ulcer?
An indolent ulcer is defined as a chronic, non-healing ulcer that is superficial and typically happens in dogs 6 years of age and older.
Okay. All right. So non-healing was a big part of that. So we'll get a little philosophical here. So all indolent ulcers are non-healing because that's part of the definition, but are all non-healing ulcers necessarily indolent?
Not necessarily. So you can also have deeper corneal ulcers that maybe aren't being managed appropriately, and they take a long time to heal. And so, but therein lies that those are deeper ulcers. So by definition, an indolent ulcer has to be superficial. And then you can also have chronic non-healing ulcers in dogs with corneal degeneration, where calcium basically is accumulating on the cornea. It gets ulcerated, and then that calcium that is still there prevents the eye from healing appropriately. So as that relates to an indolent ulcers don't have a calcium associated component with them.
Okay. All right. And then you had mentioned a little bit that there are some things that can kind of tip us off for these indolent ulcers, particularly age and breed. Could you go over kind of the common signalment?
Yep. So it's age is typically 6 years of age and older. It can happen in any breed, but the boxer breed is more prone to these than other breeds. I think if I remember right, they're 7 times more likely to develop in the boxer breed. And so if you get an appointment, where your receptionist puts on your schedule an ulcer, you look at the breed and it's a boxer and it's over the age of 6, you can almost guarantee that that's what it's going to be, or at least that should be your first differential before it walks in the door. But it can occur in any breed. And then some more breeds that are really difficult to heal, at least in the Midwest for me. There's some regional differences in some dogs, but Frenchies are pretty hard to heal, um, and corgis are really hard to heal for some reason. I don't know why, but they seem to take a little bit longer. And then in we're starting to see some indolent ulcers occur in Frenchies that are less than 6 years of age. So, but maybe that's not all that surprising given the more, should I say, creative breeding that's going on with the Frenchie breeds.
That's a nice way to phrase that. I wanted to talk a little bit about diagnosing these because you state in your article that using a cotton-tipped applicator to kind of debride the corneal epithelial tissue can help you when you're trying to diagnose an indolent ulcer, if it's not obvious right away when you put in your fluorescein stain. But could you talk to us a little bit about how it might appear before and after you've done this little debridement, and if it's not an indolent ulcer, what is it going to look like?
So if what it typically looks like is it's a superficial defect that will have loose epithelium that is associated with it. And so sometimes you can even, when you stain the eye, fluorescein will go underneath the epithelium and it will sort of have like like it looks bigger than maybe what you saw with just looking with a regular pen light or something. A lot of dogs will also have blood vessels that are associated with it, especially the boxer breed. They seem to accumulate a lot of granulation tissue because this has been going on usually for a while. Although, well, I take that back. In the general practitioner world, it may not have been going on for a while. It may have been, a day or two of their dog squinting. Usually how I see them is they're very chronic because the veterinarian has attempted to treat it for 2 weeks, sometimes 2 months, and before referral. And so I'll get a lot more chronic changes such as vascularization of the cornea. So you might not have some of those changes as a general practitioner. You can also use a Q-tip or cotton-tipped applicator as a diagnostic tool, not just as a therapeutic tool. So if you don't know if it's indolent, you can take that on the cornea and basically give the dog some proparacaine, rub it on the cornea, the Q-tip, and see if any of that epithelium peels off. If it does, then you have an indolent ulcer. Normal epithelium is not going to peel off with a Q-tip if you're just taking it across the cornea doing a debridement. So if it comes off, it's abnormal cornea and it's an indolent ulcer.
Yeah, just very lightly. I have a question about that too. When you're using that Q-tip, that cotton-tipped applicator, do you moisten it or is it just dry?
It's dry. You want it to be dry because it's called a dry debridement. Mm-hmm. And so when the Q-tip then, like if it gets filled up with moisture from the tear film, then I would throw that one away and get another dry one. Because the dryness helps to grab that epithelium and pull it off the cornea if it's diseased.
Perfect. And then, as you said, this is diagnostic, but also therapeutic. And so really this should be kind of our first line treatment when we see these ulcers before we do things like, the diamond burr debridement that we're going to talk about later, or a grid keratotomy. Can you just what's the success rate of just the dry Q-tip debridement? And, go ahead.
No, sorry. Yeah, good question. I don't know. There's got to be a study as to probably what it is, but I typically quote an owner 50%. Okay. So 50% of them will heal. And that's just from my clinical impression. I could probably pull all my numbers. I see 5 of these things a day, so it wouldn't take me long to come up with a percentage. But it's usually 50% if you debride them with a Q-tip, treat them with some antibiotics, see them back again in 2 weeks.
Yep. And that was going to be the second part of my question. So you hit it there. We really need to combine this with topical antimicrobials. So what are you reaching for first line?
So I use typically ofloxacin 4 times a day, as well as terramycin 4 times a day. The reason I use those is ofloxacin is a broad spectrum fluoroquinolone, and so it's going to hit gram positives and gram negatives. One of the mistakes I think that we see general practitioners use is using tobramycin. tobramycin primarily treats gram negatives, and most of the bacteria that lives on the eye and around the eye are gram positive. So you're kind of missing the spectrum with tobramycin. And then terramycin, we don't really use it for its antibiotic properties. We use it because it reduces MMP activity within the cornea. MMP activity is what leads to a corneal melt. So we don't want this indolent ulcer going from an indolent ulcer to a melting corneal ulcer. So it reduces the MMP levels in the cornea. And it also helps to speed epithelial migration of the cornea. So those epithelial cells, in order to get an indolent ulcer to heal, you need them to migrate, and then you need them to adhere. So this helps the migration aspect of those epithelial cells. And that was a study done by Heather Chandler out of Ohio State.
It's always fascinating to me when these antimicrobials have some of these other, effects on the body, immunomodulating effects and things like that.
Yeah.
Are you using topical or systemic anti-inflammatories, with this, or, especially after they've gone home for the procedure?
I usually don't send them home on anti-inflammatories or pain medication after a debridement. I do after a diamond burr or a grid, but I will if the owner thinks that their dog is painful. But I usually do tell them that there's not a lot of pain medication that adequately hits the eye. You just have to fix the problem. And so we use a lot of gabapentin now for dogs, and so and of course, like, I guess I'm getting to be one of the older guys now. I don't feel that old, but I'm almost 45, and the younger generation of interns and residents that come through, they're dishing out gabapentin like it's Pez, and so I just follow their lead on that. If that's what we're teaching, more pain control. When I was younger and in my residency, I was teaching my mentors how to use better pain control. So that's the direction we're going. So I listen to them about pain control. They teach me about that.
That's great. I just had my birthday last week, but I'm older than you, so I'm not going to mention it.
You don't look older than me.
Well, thank you. That was very kind of you. Okay. So getting back to ulcers, you had said that oftentimes, you're seeing these weeks or sometimes even a couple months where someone like me has been trying to manage them. So how long should I wait to recheck an eye after I've done a debridement procedure?
The most common mistake that I see is switching antibiotics rather than addressing the underlying problem. So if you have an indolent ulcer, your antibiotic choice really shouldn't be that much of a factor. And so we'll see people that might go from tobramycin to triple antibiotic and then wait another 2 weeks, and then maybe they go from triple antibiotic to ofloxacin. It's not an infected problem. It's a structural problem of the cornea. So I think what I see probably most commonly is, and I like this approach, is that a general practitioner will see the patient for this ulcer. They'll treat it. They'll see them back maybe in a week or two. Let's say it's a week. And let's say if in a week it's not healed, they'll say, we're going to maybe do a debridement at this visit, and then we're going to give it 2 weeks. But maybe then they'll put the bug in the ear, but if we don't get this thing by 3 weeks, I really think we ought to start thinking about a referral. I think that's a good kind of middle of the road approach. Of course, it's very self-serving for me to say whatever eye case you see, you should just kick it off to me, but that's not the real world. So I think the real world is you treat as the doctor you are, and you treat it until you get to a point where you feel uncomfortable or you can't fix it, and then you refer it.
Okay. And then you had said you kind of tell people 50-50 after a cotton-tipped applicator debridement. I read that after something like a diamond burr debridement, healing can be reported to be about 80%. So that's a pretty good success rate. Kind of what you were just kind of alluding there to, is that success rate based really on referral or tertiary facilities doing this procedure, or is this,
Yeah.
Yeah.
Yeah, it is. It's based on, because the studies were all done in either, they're all done at referral practices, whether they're
Mhm.
private practice or excuse me, or in academia. And I usually quote a 90%. So anything from a 80 to 90% is a pretty good statistic, I think, to give.
Okay.
I think
And
the more you see and the more you treat and you kind of get your timing down better, I think your success rate starts to go up.
then what, if any, are any contraindications for this procedure?
The biggest contraindication is you have to have a correct diagnosis of an indolent ulcer. So it can't be infected, it can't be deep, it can't even have 10% of depth in the cornea. It has to be an indolent ulcer. Otherwise, you're going to make it way worse real
Okay.
fast. So, and I think
Okay.
that that's the scary part about it.
Right, exactly. So yeah, so the complications that can arise if the ulcer is deeper are pretty severe.
Yeah. Yep.
Now, um, as I said, this was, there's this diamond Burr debridement, which we're going to talk, about the procedure in detail, but there's also a grid keratotomy. Could you just really briefly explain why you choose one or the other, and when you might, do that grid keratotomy instead of the procedure we're going to be talking about today?
A grid keratotomy is it came along before the diamond burr, and you use a 25 gauge needle, and you basically are creating lines in the cornea in crosshatch marks. So it's like a giant multi-area tic-tac-toe board. And so I don't like to use that procedure, because it leaves a much bigger scar on the cornea for years. I mean, you can see dogs that may have had a grid keratotomy done 2 years ago, and I can still find grid lines all over their cornea, with the slit lamp. But that being said, in dogs with um, endothelial disease, where they have a lot of corneal edema, those dogs are a little bit more prone to develop indolent ulcers, and those dogs don't respond very well to diamond burrs. They respond better to grid keratotomy. So if they've got endothelial degeneration and they're developing these indolent ulcers, then a grid keratotomy is the way to go on those.
Okay. When you've got a challenging case in front of you, you could spend your lunch sorting through cluttered search results and a shelf full of outdated textbooks. Or you could find what you need to know in seconds, all in one place. By combining concise diagnostic and treatment information, algorithms, and pet owner resources with the drug information veterinarians trust, Plumb's Pro is ready to change the way you spend your day. This groundbreaking new platform is streamlined, easy to use, and continually updated to keep you delivering great care with confidence. Now you've got one less reason to eat lunch at your desk. Get acquainted with the all-new Plumb's Pro at plums.com. So now let's go ahead and walk through the steps that we're going to perform when we do the debridement with a diamond burr. The first step you mentioned in your article, which I found surprising, is optional, and that step is sedation. So can you tell us, like, what percentage of your patients do you typically sedate for this procedure?
I try to sedate 100%.
Oh, okay.
I try to. Um, but any contraindications to dexdomitor, or if so, like cardiac disease, severe cardiac disease, I try to do those without sedation. Also, sometimes we'll use just like a half dose of sedation so that they're not completely like conked out for the whole afternoon. Especially uh, especially the more round patients, dexdomitor will keep them down for a while, and then you have to have a tech with them, and that goes on for quite a while. Um, or if they have any significant neurologic disease, I try not to sedate them either. So if they have seizures, or if a client really is opposed to sedation, then I try not to. But as long as it's clinically applicable, sedation is better to treat them. because otherwise they're not putting their third eyelid up in the way the whole time. They're not pulling their eye back. They're not struggling. It follows more of like a calm sort of routine procedure for the clinician and the dog.
Yeah, that's interesting because I was wondering if sedation caused any of those things, particularly third eyelid elevation or kind of, rotation of the globe, which might, potentially complicate your visualization for this procedure.
Yeah, you're right. It sometimes can move the eye a little bit. Sometimes, especially in the dolichocephalics, they have their third eyelid will come up, but you really eliminate the squinting and the straining, which is helpful.
Okay. So moving on to the next step, that is going to be your anesthesia. So you apply a topical anesthetic, and you already talked a little bit about proparacaine, which really in my 20-year career is I think the only topical ophthalmic anesthetic I've ever used.
Me too.
Are there others?
Yeah, there's like tetracaine and some other cane drops out there, but I've only used proparacaine.
Yep, that's what I've used too. So, and then are there any other specialized instruments that I'm going to need in order to, open the eye or stabilize the globe?
You can use some Colibri forceps if you want. It's spelled Colibri, and they're pretty atraumatic, and they're made to grab conjunctiva. And so you can use those. You don't want to use like Brown Adsons or Bishops or anything like that. That's too traumatic for the eye. But you can get some pretty inexpensive Colibris and rotate the globe that way.
Okay, and then after you're there, you've got your eye stabilized, you say to perform another cotton tip applicator debridement, so another dry debridement. And why is that?
Because if you already have done a debridement, then in the time frame that's more than, let's say, a day between doing that debridement to now, those epithelial cells are going to be more prolific, and they were trying to migrate across the cornea, trying to adhere to the cornea. So you want to get those all out of the way, just so that you're getting rid of as much epithelium as possible.
Okay. And then I will admit that as I've gotten older, we were talking about birthdays and age, my own eyesight has gotten a little bit poorer with time. So are you using loupes or magnification, and what should this ulcer really look like, so I know I'm ready to move on to the next step with the diamond burr?
So I'm a big fan of loupes. I don't have to use loupes yet for this procedure. I'm sure it's coming. But my eyes are also, obviously I wear glasses and they're progressive. So yeah, I'm with you on that. Loupes with like an LED headlight are awesome for something like this. And really what you should have is before the diamond burr is you shouldn't have any extra epithelium on the surface of the cornea. It should look like a pretty flat cornea.
Okay. And it's, my understanding is it's kind of dull in appearance, right?
It's dull because you just you dry debrided it. And so it's not going to have much tear film there.
Okay. So let's talk about that diamond burr. Obviously this is a dental instrument, right? And so, yeah. And so, diamond burrs, they do come in different shapes and things like that. So can you just describe like what burr you want, what shape, how do you hold it?
Yeah, the burr that we use most commonly is it's blue. It's blue, and it's maybe 4 or 5 inches long, and you hold it like you would a pencil, and you kind of go over the surface of the cornea like you're drawing on the cornea with a big fat pencil. You just want to make sure that you use the right tip. The tip that you want to use is the more round one, not the little teeny tiny round one. That one's more like a drill, and you don't want to use that because that'll do too much damage.
Okay. And then, you mentioned when we do the cotton tip applicator, we want it dry. So do you do this dry as well, or do you use any kind of irrigation during the debridement?
No irrigation. By this time, the tear film's kicking back on anyway, and so you should be running the diamond burr for 45 seconds, roughly 30 to 45 seconds. And so by that time, you've already got the tear film back in play.
Okay. All right. And then that part's over. Now we want to protect the eye a little bit. And so you definitely recommend placing like a bandage contact lens. I've never used one of these. So where do I get them? Do they come in different sizes for different breeds? I have questions.
So like you can get them from Bausch and Lomb. You can get them from Vision, which is AN-Vision. And since there's such a variety of dogs of sizes, obviously Chihuahuas to Great Danes, it usually is pretty much a one size fits all. Oddly enough, they seem to stick the best on a boxer, which is good for the boxers because they're the ones who come in the most. We actually use them. We have like friendships with human optometrists, and they'll bring us expired bandage lenses because you can't use them in people, but we can use them in dogs. And so we'll use those, and they work out just fine. And they do look to be different sizes. But if you're going for just a straight dog one and you're just getting started, probably buy the ones from Bausch and Lomb or the ones from Vision.
Perfect. Thank you. Sometimes these do, even in the hands of somebody very experienced as yourself, these do require multiple treatments. So, how long do you wait between those debridements? And if I do just one debridement as a general practitioner and I still have a non-healing ulcer, is that when I really should send this to you?
Yeah, I wait 2 weeks between everything on these. So just a Q-tip debridement, I do that. I'll wait 2 weeks. Diamond burr, I'll wait 2 weeks. Before the recheck, if they come in, they're not healed from the diamond burr, what I usually do at that point is I just do another debridement with a Q-tip and then take the e-collar off the dog. It gives the clients a break from that mess. Give them another 2 weeks. Some of those will then be healed. And then I tell them if they're not healed in 2 weeks, we'll have to do a similar procedure called a grid keratotomy, and to kind of tie it back all together again. But I think giving them that 2 week period in between the diamond burr before the diamond burr, then you do 2 weeks and then a Q-tip and then another 2 weeks. It gives the client a way to financially recover, and depending on what area the country you're in, some of these are very, very expensive. Well, I shouldn't say very, very. I've seen people charge anywhere from $400 total to $1,800 total. So it gives them a break financially, and it gives them a break to stop getting the back of their legs beat up by the e-collar.
Yeah, I have had multiple dogs over my lifetime of my own that run into the back of my legs with their e-collar. It's always so. I always feel bad for clients whenever my own dog needs to wear an e-collar, and it makes me remember my empathy.
I got a big kick of empathy just the other day because clients complain about these e-collars left and right because I use them all the time. Mm-hmm. I get so tired of hearing about it. Well, I had to have an IV line in my own dog the other day at home, and so I put an e-collar on her so she couldn't get to the IV line. And God bless it. I mean, running into everything, and it was maybe 15 minutes before a cuss word came out of my mouth. So I'm like, oh. That's what my clients are complaining about all the time, and how annoying this is. And I'm the one dishing out the punishment, and I can't even take my own punishment for 15 minutes.
Yep. I've had that happen. All right. Last question about indolent ulcers. Are these usually unilateral, or, what percentage of dogs that get an indolent ulcer, like in one eye, go on to actually develop ulcers in the other eye?
I think it's probably higher than what I would knee-jerk estimate. I was going to say 50-50 to get one in the other eye, but I think it's probably closer to 70-75% in the other eye. And you do sometimes see them at the same time, where they'll have them bilaterally.
Yeah. So that might be another place where we just kind of gently prep the client. When we see one of these, we're going to go through, what could be a long treatment process, as well as kind of expensive. And there's no guarantee that we might not have to do this all over again in the other eye.
That's exactly right. Because if you have them you're essentially now with a bilateral case, you're dealing with essentially two separate patients. And so one might heal and the other not heal. Maybe neither one of them heal. And then you got to do this whole protocol of 2-week rechecks. Maybe both of them heal and everybody's happy. Yay, move on. But yeah, you're right.
Yeah. It kind of reminds me of that conversation I have anytime I diagnose a cruciate ligament injury. So
yeah, exactly.
Well, like I said, that was all my questions about this procedure. This was fantastic. As always, it's so much fun to talk to you.
Me too.
But I'm not sure, did we scare you off last time on rapid fire questions, or do you want to play again?
No, I love rapid fire.
All right, excellent. Okay, so new rapid fire questions for you today. Would you rather have all of your clients speak only in rhyme or have to explain all of your discharge instructions using only interpretive dance?
I got to go with the rhyme on that one.
The rhyme. Okay.
Yeah,
Not a dancer?
Not a dancer. I got no dance moves.
Would you rather your ophthalmoscope always be slightly out of focus or your tonometer always read 5 millimeters of mercury off in one direction or the other, but you don't know which one it's going to be?
Ophthalmoscope, because then it puts the problem on me instead of on the dog.
Okay.
So,
all right.
Yep.
Here's one. Do you treat your own pets or do you have a trusted colleague do it?
If it's well within my reason of eyeballs, it's all me.
It's all you. Yep.
It's all me. If I only trust myself with eyeballs or someone I trained.
Okay.
Yeah. If I trained them, then I trust them. The other exception to that is my colleague, Ron Spatola, who was trained by someone else, but he's an excellent ophthalmologist. So I trust him too, but I prefer to do that myself. But anything else, I'm kicking it to the best person I know how to treat that problem.
Absolutely. Would you rather be stuck in the clinic listening to a hyperthyroid cat or a dysphoric husky?
Oh, the cat. It's got to be the cat. I can't deal with dysphoric husky. I can't deal with dysphoric anythings, and I really don't like vocal anythings. So yeah. I'll go with the cat.
Yeah. Although I don't know, those hyperthyroid cats can yowl pretty loudly as well.
They can.
Okay. Last question. Would you rather have to administer eye drops 6 times a day to like a giant T-Rex sized Chihuahua or to a Chihuahua sized T-Rex?
Oh, a Chihuahua-sized T-Rex. That's just a normal Chihuahua.
That's true.
That's just a normal Chihuahua.
That's just a regular Chihuahua. You're right.
If it's just this big and mean, that's a Chihuahua. And I do that every day.
Yep. So you've got that one down.
Yeah.
All right. Okay. Well, that was all of them. I hope you had fun again.
I always do. Thank you for having me.
Thanks, everybody, for joining us. We'll catch you next time on Clinicians Brief the Podcast. Thank you for joining us for today's episode of Clinicians Brief the Podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.